So my session, the next 20 minutes, and then we'll hear a surgical perspective and have some Q&A. It revolves around treatment. Of course, treatment for pancreatic cancer is quite complex and not something that I think we can do everything in 20 minutes, but I'd like to give a little bit of an overview of sort of where we are and maybe a little bit about how we got here, just through a lot of work and effort and support. But also, of course, where we hope we're going. So what are some of the advances and what are the future treatment options that are being explored right now? So here's, I just said that. So here's a little bit of an outline. I want to talk a little bit about our treatments and our outcomes, which is, we've seen before and we'll see more, are clearly not where we need them to be. Talk about a little bit about new data. And so this is periodically different researchers try to catalog the research that's been done to understand new treatments. And this is a report that came out last year looking at around 25 years of studies and reported that there were 481 phase 1 clinical trials and 85 phase 3 clinical trials targeting patients with advanced pancreatic cancer. That's a lot of trials, a lot of patients, a lot of investment. There have been 5 new drug approvals over the last 20, 25 years. That's good. As you're going to see, and as we all know, it hasn't been enough, right? So clearly the goal is not number of trials, it's changing outcomes for patients, and we're not where we need to be. And then I'm going to talk, hopefully in the last few minutes, as much as I can, about the future, right? We have some new therapies that are coming, that are being developed. We have many, many clinical trials, and super important to continue enrolling and participating in those trials. And of course, very important to understand how we can advance patient care besides just using medication and other interventions, but using supportive medications. So this is data, of course, we've seen it all in some format of just numbers. These are estimated numbers for the United States for 2025. And you can see these are the top 10 by number, numerically, causes of mortality in cancer among men and women. Pancreas cancer, unfortunately, is very close to the top of these lists, even though, as Dr. Ganda pointed out earlier, it is a relatively rare cancer. So although it happens much less frequently than the 8% mortality, and this is a percentage of all cancer deaths, this is certainly a high number and one that we need to decrease. This is, in one slide, really describes 25, probably more than 25, 40 years of clinical trial and clinical research in pancreatic cancer. Of course, you can't capture decades of work in one slide. Unfortunately, the advances are thus that we can get all the drug approvals on this one slide. And so, the main mission we have as pancreatic cancer researchers and clinical trialists and treating physicians is to make this slide, tiny so that we can add dozens and dozens of treatment options and variations. And of course, there are many, many things that we use in care, including radiation treatments, surgical treatments that are not reflected. This is a chemotherapy slide, essentially. But what you see here is that over the middle of the 2010, 2013, there were 2 new multi-agent chemotherapies that were approved. I'll go through them in a little bit, but not in much detail. One is called FOLFIRINOX, one is called Abraxane and Gem-nab-paclitaxel. These are very important regimens. They are effective. They also have side effects, and we have to, of course, learn how to use them most effectively. There's one little box for immunotherapy, which is very exciting, but unfortunately very small. So currently, the only approval we have for immunotherapy in pancreatic cancer is in patients who have what's called MSI-high tumors or Lynch syndrome-associated tumors if it's germline. This is a rare population. It's probably around 1% or maybe even less, somewhere between 0.5 to 2% of pancreatic cancer patients in which immunotherapy is a good option. But for 98 or 99% of patients, that's not something that's standard. We certainly have clinical trials, and we're trying to expand that. That's where it currently stands. There's also a small population here on the bottom right of patients with germline BRCA mutations. We heard about these patients earlier from a screening and risk factor. They are actually a distinct patient population. This is a slightly larger population, probably around 4 to 6% of patients with pancreatic cancer have a germline mutation in BRCA1 or 2 or associated genes. Those patients have unique outcomes. They have, as you see here, a therapy called olaparib, which is approved only for them because of the way it works. And it is something we utilize in that patient population. And then in 2023, so 2 years ago now, almost 2 years ago, there was a new study and last year a new approval for another first-line agent called liposomal irinotecan in combination with other chemotherapy agents. This is a slide, this is actually from the study I commented on in the beginning, where this group looked back at all the clinical trials done in the last 25 years. And one of the points that they're trying to make here, it's a little bit complicated if you want to see it, is that there are many, many clinical trials done. There are 5 FDA drug approvals. There really are variations on the same 2 drugs. One is called gemcitabine, which has been combined with Abraxane. One is called 5-FU or 5-fluorouracil, which is now used in FOLFIRINOX or NALIRIFOX or variations of that. So it's really 2 backbones and variations. But what has happened over time, this is quite interesting, on the right side of this cohort is the number of patients enrolled in trials. And what we've been able to show is that we're able to accrue far more patients in trials. So people are participating in clinical trials at higher rates, which is very encouraging. These are not including many other trials that patients enroll in. And that's great. We want to continue that. That's obviously done through a lot of advocacy. Patients have to give of themselves to go on a trial. They have to know about the trials. We have to have the trials. So we have increased our rate of accrual and our pace of trials. We don't yet have information, as I mentioned, about these 2 regimens, gemcitabine and 5-FU. It's hard to say which one is better and when to use them. There's very little direct comparison. So I'm just showing you one study. It's an older one, now it's 6 years old, where they gave in a different setting, patients prior to surgery, the 2 regimens, so FOLFIRINOX or Abraxane. And the details here are not what I wanted to go through. It's that they're clearly the same, right? So in this small study, there was overlapping outcomes from what's called a Kaplan-Meier curve for the 2 patient populations. This is not, of course, the only study. There are other studies, but essentially, I would say a lot of our data so far does not tell us how to choose one regimen over the other regimen as a first-line option. This is the one study that I want to highlight that does do some of that. This was published now 2 years ago. This is called the NAPOLI-3 trial, where 770 patients with metastatic pancreatic cancer were enrolled, and they were randomized, so 1-to-1, 50% chance based on the computer and other variables, other stratification factors. Patients were selected to either get NALIRIFOX, which is a combination regimen. As you see here, again, the details are very specific, and I'm happy to go through them, but they're not so important. It involves nanoliposomal irinotecan, 5-FU, leucovorin, and oxaliplatin, or gem-nab-paclitaxel, and patients were followed over time. And in this study, there was a slight but consistent benefit in just the 2 curves you see here in the 5-FU-based regimen, the NALIRIFOX regimen over Abraxane. I'd say it was a small but significant, you can see benefit there. And so that's one of our only and by far the biggest trial we have of comparing these 2 agents in metastatic pancreatic cancer. In practice, and this is a lot of words here, but in practice, this is what we do as oncologists. This describes sort of our entire job, right? So we have to utilize the information that we have from the many clinical trials and customize and tailor treatment for each patient. So we look at different settings of therapy. So there's something called adjuvant therapy, which is chemotherapy after surgery. There's something called neoadjuvant therapy, which is chemotherapy prior to a planned curative intent surgery. There's therapy that's palliative or for metastatic patients. So in all of those circumstances, we have to take into account the available data, the known regimens. We know there are 2 good regimens. I would say most patients who need them should get both. The question is, which one's first? If it's a curative intent surgery and adjuvant therapy, hopefully they only need one regimen. But if they need both, how do we sequence them? How do we give them? And it's really tailored based on side effects and other variables. So that is a lot of what we do now. Of course, I'm skating over the details, but that's really how we utilize chemotherapy. One of the really, really important points is what do we do after that first choice, right? You choose a chemotherapy, you start treatment. Unfortunately, for patients with metastatic pancreatic cancer or non-resectable, so they can't have surgery, they're not going to be cured with chemotherapy. No one will be cured alone with chemotherapy. And so after we give a first-line chemo, we have to think about using second-line chemo or other lines of therapy, including clinical trials. And usually we recommend chemotherapy. This is just a very important table from that trial that I described, the O'Leary-Fox trial. They looked at how many patients on this trial got second-line chemotherapy. So these were patients who enrolled on a first-line clinical trial. They were already a select group of patients. And as you see in the top line, any further subsequent anti-cancer therapy, really only 50% of people got any therapy after their first-line therapy in this clinical trial setting. We know in the real world, it's even fewer people. And so this is a real failure, I would say, of our treatment options because we have chemotherapy that's beneficial. We're not getting it to enough patients. And so we need to do a better job as the medical providers, as communicating, as understanding how to select therapy to make sure that we're utilizing the currently available best therapies for every single patient. And that's not easy. It's easy to say it. It's very hard to do it. And it's something that, certainly with patient awareness and advocacy groups and, reaching out and asking questions, we can certainly make a dent in the outcomes and the survival from pancreatic cancer. But the big question for the rest of my talk is, can we do better? And it's an easy answer, which is yes, right? We can do better. We will do better. We must do better, right? There's clearly not where we want to be. So the question is how, and this is a lot more complicated. So as I already illustrated, I think we have currently effective therapy. It's not curative therapy, but it is effective at least for patients with metastatic disease. We have to make sure people get it. We have to make sure that they get not just the chemotherapy, but the supportive medications to help them tolerate chemotherapy, the discussions about what the best sequence is, the best regimens, how to use every modality we have, including surgery, radiation, advanced targeted therapies. We've got to make sure that what we have is being utilized. But the second thing we need to do, as we've heard already, is we got to do better, right? So we have to invest in new drug development, new treatment development, if it's not drug-based, if it's device-based or some other modality. We need to invest in science. I think there has been a lot of investment. You heard a little bit about, the fear of what's going to happen going forward if that investment changes. But certainly there's a lot going on. We've got to work and collaborate and invest in those efforts. And then the main thing that, I think is going to change how we treat patients are utilizing these new medications, these new drugs in clinical trials, because without well-designed and well-run clinical trials, it's very hard to learn how to treat patients. And so we've got a lot of clinical trials going on. We spend a lot of our energy in evaluating these trials, bringing these trials, enrolling patients, supporting patients, and then of course, reporting the results of those trials. And so trials that I'm going to go through that we are excited about and that actually are in late stages already involve novel chemotherapies and new combinations. So we've got new things coming down already in trials that we hope will make a big difference. Targeted therapy, which I think is going to be the most impactful thing in what I do and what we do in clinical trials, right? If we can identify, which we can, many of the mutations in pancreatic cancer, and we could target those mutations, we can make a difference in many, many people's lives. And the most notable of those targets is a gene called KRAS, which is a very, very important gene. It's mutated in over 90% of all pancreatic cancer patients. There are different types of mutations in KRAS, so not everyone has the same type or the same expression. And so it's complicated, but we are in late stages of drug development to have targets for that gene. And then finally, something I'll say only a little bit about, which is something that we've worked a lot on at NYU, are immune therapies. So we have not yet cracked the code for getting the immune system to recognize pancreatic cancer and target it. But we have some really innovative trials that are trying to do that. And we're optimistic that they will make a big difference once we get the right regimens. So going through each of these things. So chemotherapy, I'm not going to go through again the details. It's not so important because they will change as we go through trials. But there are new agents. We've actually completed recently, we've been part of them at NYU, and they're multi-center trials of several new targets, including an antibody called a CD73 antibody, which affects the adenosine deaminase pathway. Very exciting results that we presented last year, and there's now an ongoing phase 3 trial of one of these agents and several other in development. There's something called Claudin, which some people might have heard of, Claudin 18.2, which is a cell surface molecule, and there are antibodies now approved in stomach cancer that we're testing in pancreatic cancer. We're looking at a whole new class of drugs called antibody drug conjugates, which is a class where you take an antibody which targets a specific surface molecule on the cancer cell and attach a drug to it. So you're basically delivering a cytotoxic or a chemotherapy drug at the right site. And we have several of those in trials with early encouraging results. And then, as I mentioned earlier, we're looking much more specifically at targeted therapy. So what is targeted therapy? So it's exactly what it sounds like, right? The goal of targeted therapy is to find a target, to find something that is specific to the tumor cell. And in many cases, it could be the surrounding cells, the blood cells around the tumor, what are called the stromal cells or the support cells around the cancer. As long as it's specifically in the tumor and you can target it there, you can avoid targeting other healthy cells and reduce some of the side effects while achieving a lot of benefit. And there are many different types, as I enumerate here: antibody therapy, antibody drug conjugates, small molecules, something called CAR T cells. But the main thing I would point out is that we can't target cells if we don't know what's on them, right? And so it's absolutely essential to characterize a person's pancreatic cancer, maybe all people's pancreatic cancers, but even on an individual level. We do that with something called molecular testing, which is standard. It should be for every single patient with pancreatic cancer, regardless of the stage. And then in development, we have many more advanced tests looking at further understanding of what's driving a tumor, if it's beyond the molecular level, using some other data, it's called functional data, to look at more advanced understanding of each person's tumor to identify targets for that tumor. The most notable, as I said, target is KRAS. It's a gene that's mutated in over 90% of pancreatic cancer. This is a very nice schematic from a company called Foundation Medicine that just basically gives you a sense that in a normal cell on the left, most of the KRAS molecules, KRAS proteins are off. A very small number are turned on. But in cancers like pancreatic cancer that have KRAS mutations, that gene and therefore the product of the gene is turned on, right? And so it constitutively is active and it drives those cells to grow and not die in different ways. And it drives the cancer. And as you can see here on the right, there's hundreds of thousands of patients, including most pancreatic cancer patients will have this mutation, many colon cancer, lung cancer patients as well. And therefore, if we can stop this gene, if we can figure out how to stop the gene or the protein, we can have an impact on many patients. There are several studies. I'm just going to show data that we presented earlier this year, actually in October of this year, so 9 months ago, or even less, from a novel medication called RMC-9805. It doesn't have a name yet. It's one of many compounds that we are currently testing in clinical trials. What this graph shows is basically the change in size of tumor. The numbers are not so important in this graph, and you probably can't see them from that far away. But what you can tell is there's a lot that's below the line, and that's what we want. This means that tumors are getting smaller. When tumors get smaller, for the most part, people feel better, right? Their markers come down, they have less pain and less symptoms, and they live longer. So this is something that's very favorable, very encouraging from a pill that people are taking once a day. It's still very early. So this was a preliminary data from a trial. The trial is ongoing. We're actually combining it with other things. And this is not the only one. This is one I just happened to show data for, that these drugs are in the clinic. And so I would say from a numerical standpoint, we are working with many companies. I know of over 20 that are developing these drugs. The first ones are already in phase 3 trials. We at NYU have 5 and more coming phase 1 trials that are all looking at novel drugs for this. We've got a lot to learn, which is exciting. We need to support it, right? Which ones to use, when to use them for any particular patient based on that person's mutation. And of course, the last line here is going to keep us busy for quite some time, which is combining, right? Whenever you have a new medication, does it work with other chemo, with surgery and sequence, with radiation, with immunotherapy? We're going to ask all these questions, and the only way we're going to get answers is through clinical trials. Finally, I'm going to show this just because it's very exciting. This is a sort of schematic from a very neat website made by a patient's family who are very interested in cellular therapy. This is a kind of therapy taking a patient's T cells, you can see on the left from the tumor or the blood, changing them and to engineer them to target a tumor and injecting them back into the patient. And we do this in pancreatic cancer in clinical trials. It's quite an advanced technology. It's very interesting, and we're hoping that it will end up leading to application for many patients. I'm going to skip this section. Sorry. So in summary, finally, we're out of time, but I'd like to say there's been tremendous investment driven by patients and patient advocates and clinicians as well to do these trials to make progress in pancreatic cancer. We need much more. We've got novel medications in late stages, and the best thing we need to do is expand these trials, get drugs from pharma companies and from access to patients, and ask the right questions about what matters to patients in order to get trials and drugs into patients to change their outcomes as quickly as we can.
Okay, well, while they pull up my slides, I got to say, I always have to speak after Thomas Gonda and Paul Oberstein, who are much smarter than I am, but so it's always a tough act to follow, but I think they'll both agree, at least I'm better looking and more friendly than they are. So I got that going for me. So I'm one of the surgeons here, and it's a privilege to talk a little bit about surgery for pancreatic cancer. It's a privilege to be part of this group. It's an amazing time here right now. We somehow have attracted the best and brightest and have, I think, one of the most talented surgical groups in the country. I can just see here in the audience, Brock Hewitt is sitting in the front, Gary Deutsch, Brian Kaplan, Amar Javed, who's one of our surgeon scientists. I see Michael Kluger in the back of the room there trying to hide, but they're really among the who's who in terms of pancreatic cancer surgery and pancreatic cancer research. So any one of them could be giving this presentation, and in fact, Gary will be talking after me. So I'm going to talk a little bit about surgery, and the way I'm going to do it is I'm going to address 4 questions, which I think are some of the most common questions that I always get. And through this, addressing this series of questions, hopefully understand a little bit about tumor biology and how it relates to affecting a cure, and how surgery plays a role in that. And it's not surgery alone, it has to be chemotherapy. Now, I will say that I think it's important to note that the only potentially curative therapy for pancreatic cancer is surgical resection. So for all intents and purposes, without surgical resection, there really cannot be a cure. There are some exceptional cases where we have long-term survivors without it, but we can cure people with surgical resection, but it's often not sufficient in that we need chemotherapy, as Paul just talked about, and sometimes integration of radiation. But I do think I want to make a point as I'm a bit of an optimist. I know that we have a tough battle in curing folks, but we have examples here today that pancreatic cancer is a potentially curable disease in some individuals, and hopefully that number is getting more and more as chemotherapy gets better and as some of the surgical innovation gets better, which I'll talk about. So I'm going to be pretty basic about it. What is a pancreas cancer operation? That topic came up a little bit today, distal versus a Whipple. Why is removing the tumor not always curative? You think you would take it out and then you're cured. Why are some people not a candidate for surgery? And then finally, what innovation is happening in surgery? And it'll sort of be a segue into Dr. Deutsch's lecture. So what is a pancreas cancer operation? Well, let's see. Do I have a pointer here? Nope. So yeah, here we go. So this was a little bit of a discussion earlier. So tumors can grow anywhere within the pancreas. That is a cartoon of the pancreas. It has a head in this region. The head is made up by the uncinate process. It has a neck, that portion which lies over the portal vein, and then it has a body and a tail. And tumors can occur anywhere in this area. We often will do more head resections for pancreatic cancer, usually because it impinges on the bile duct, which is right here, and people become yellow, they turn jaundice, and it sends a warning flag up. And although that's a scary thing, we tend to catch them a little bit earlier. On the left side, they can grow larger and tend to spread more and are not necessarily a candidate for surgery. And so it's less common to do a resection of the tail for pancreatic cancer. And I will show what those resections are and talk a little bit more about head versus tail shortly. So in a head lesion, a Whipple operation is performed. A Whipple operation, or pancreatic duodenectomy, or if you're in Europe, it's a Couch Whipple. takes out the head of the pancreas, so it takes out the head. This depicts the tumor here, the uncinate process, so the neck of the pancreas is divided, the stomach is divided. In some variations, we divide the stomach further distal, right where it joins with the duodenum. The duodenum is removed. This is first, second, third, and fourth, and it's divided right as it meets the jejunum. This is removed, and what it leaves behind is people still have a portion of pancreas. They still have a stomach. They still have a bile duct. By the way, the gallbladder comes out, which is not shown here. I guess I had those pointers on there. So in a Whipple operation, people don't realize this, but pancreas is way up high in the chest, and it's not in the front of the abdomen, it's toward the back of the abdomen. So one of the first steps in getting to the pancreas is to mobilize that right colon. And you can see here the head of the pancreas, and this depicts the tumor. So organs don't necessarily have to be taken out, but they have to be moved around to get to the pancreas. The area called the porta is dissected. This is a very busy area within the abdomen. The blood supply to the liver goes through here. The gallbladder is removed for reasons I could explain in the discussion if you want. It's attached to the bile duct. We mobilize the duodenum, or the first portion of the small bowel. And as you saw in that first picture, all of this area is removed. And here you can see the stomach folded over, and then the next step in this is to divide the pancreas over the neck of the pancreas. And then we divide the jejunum. And now the specimen, or the tumor-bearing portion of the pancreas, and again, pancreas is left behind, is only attached really to the major vessels. And so the next step, we divide that neck of the pancreas right here. And here you can see the neck of the pancreas divided. And then we roll the portal vein out of that, and it gives us access to the uncinate process. The final step in getting the specimen out, and this is the key margin, and margins are wherever we cut, we want to have free of tumor, is to take down the uncinate process. And it really is not how it looks, but it's sort of a cartoon of what is the anatomy that's affected. Now you're left with pancreas and bile duct and stomach, so those have to be reconnected. The most problematic of the reconnections is connecting the pancreas back to the small bowel, and that's called a pancreatic jejunectomy. This is a cartoon of how it looks. It's typically done in 2 layers, and that anastomosis is, or reconnection, is shown right here. The next is the bile duct goes back to the small bowel, and then this usually goes under the colon, and which is not shown here, and then flipped over to the top of the colon, and then the stomach is attached to small bowel. So that you still have pancreas, you still have endocrine function. It depends a lot on your baseline, how much endocrine function you have. You have exocrine pancreas function. Pancreatic juice goes into the intestine. It mixes with the bile, which emulsifies fat. And this is sort of almost like a new bile duct, or new ampulla, which carries the pancreatic juice and the bile back to where the food enters into the what's called the efferent limb. And so that digestion ultimately will be not normal, but will get back to a reasonable level. The distal pancreatectomy for tumors in the tail of the pancreas is a bit more simple. Again, this is really not, and it's not how it's done, but it displays the anatomy. We have to take both the artery that supplies the tail of the pancreas and the spleen, and then we take the vein and we divide the pancreas. No other organs are taken besides the spleen, and then the tail of the pancreas is oversewn. And people often ask, why does the spleen need to come? Well, sometimes it is involved with the blood supply, but there's a general principle. In order to do a cancer operation, we need margins so that where we cut, we're free from tumor. So we have to, in the head, that's a Whipple operation. In the tail, we need to make sure you can see where the knife is dividing the pancreas. We're away from the tumor, but we also have to take the lymph nodes out. Lymph nodes drain that lymph fluid in which there's cancer cells, and it sort of filters that and captures those cells. And so, at least for staging purposes, we want to do a lymphadenectomy. And in the tail of the pancreas and body of the pancreas, many of those lymph nodes that are sort of incorporated within the spleen itself would be hard to separate it out, are taken. So why is removing the tumor not always curative? You think, okay, well, you take the tumor out, now we should be good, right? Or we caught it before it spread. But this demonstrates why that's the case. In people who do have a recurrence, What is that pattern of recurrence? Where do you get it back, so to speak? And it's really not that we get it back, it's residual disease, as I will explain. It's almost always systemically. So it's not really at the site where we take it out. It comes back most commonly in the liver in those people who do get it back. So what does this say? And there's a lot of detailed research that supports this, but clinically localized pancreatic cancer is not biologically localized. It's really a systemic disease. So we take out the tumor itself, but disease has escaped that already. And how does that look? Well, a pancreas tumor starts with a precancerous lesions. We heard Dr. Gonda talk about IPMN, that's one. There's a microscopic lesion called pancreatic intraepithelial neoplasia, or PANN. These cells then proliferate until they become mutated to the point where they can break the basement membrane. That's what defines a cancer, when they can invade the basement membrane. And by mechanisms, some understood, some not understood, they get into the circulatory system, and they're called circulating tumor cells. They go wherever your blood system goes throughout your body. For, again, reasons that we know part of the mechanism, but not all of the mechanism, they'll extravasate or leave the vascular system, and they will set up these micrometastatic lesions. Now, we know that they exist, and even patients with micrometastatic lesions can be cured, but some people have a higher extent or have resistant micrometastatic lesions. If we did tests or studies, the standard imaging studies, we would not be able to see those. But when we say, okay, it comes back, it's not so much that it really comes back, it's that this grows into a tumor in of itself, and then it becomes stage 4. So in order to cure somebody with surgery, we not only have to remove the tumor. In a small percentage of patients, maybe 6 out of 100, no disease has spread, and surgery alone is curative. Now, we don't know who those 6 out of 100 are. We just know that based on historical data. So we depend very much on the chemotherapy. And this is why I think it is a very optimistic time, because there's been some changes in surgery, which we'll talk about, but the real optimistic thing is that the chemotherapy has gotten better and better and better. And I won't show you all of the curves, but the survival curves are improving. Now, if you would go back in the past, you'd say maybe 1 out of 10 is cured. In some instances, when you have a really strong pathological response to the chemotherapy, now 6 out of 10 are being cured. And so I really think it's an optimistic time. And this stuff is not theoretical. This really exists. This is the culprit right here. This is a single cell that has escaped the tumor. We drew blood and took it out of the blood. This one has mesenchymal type markers, which makes it a bad player. This single cell is able to go anywhere in the body and set up in the liver and proliferate. It has stem cell features, so it can replicate and reproduce itself and reproduce these metastatic lesions. And so even in terms of research, we're starting to understand a lot about the disease that escapes the tumor, and that will be important in guiding future therapy. So in surgery, it's not about what we take out. You know, that tumor's sitting in a bucket in pathology. It's not going to hurt anybody. It's what we leave behind, and that's the importance of the chemotherapy, is to get rid of that. The more effective the systemic therapy, and as Paul pointed out, it's getting better and better and better, the higher the impact of surgical resection. So in other words, if we could eradicate all of those little cells, like I showed you, surgery would be a curative 100% of the time. Are we there yet? No, but I do think we will get closer and closer in the next 5 years. Now, why are some people not a candidate for surgery? This is also a common question, and I'll just simply do that by going through the points. There's a lot of data to support this. But you saw how those cells escape the tumor, and then they set up shop, usually in the liver. Well, often at the time of diagnosis, in fact, unfortunately, most commonly at the time of diagnosis, when we do the first imaging, the horse is out of the barn, so to speak. So that local therapy with surgery or radiation is not really going to help, because the biggest problem is the disease that has escaped the tumor. Now, there's not much about my surgical talk that gives hope on this, but what does give hope is that what Dr. Gonda was talking about earlier, the improvements in early detection. And as we detect people at earlier and earlier stages, we're going to have more and more potentially curative patients. As the chemotherapy gets better and early detection gets better, I really think that we'll see the needle move in the number of cures. Some people are not candidates because of major vessel involvement, and I'll talk about that for a bit. And some are just simply too frail, as these are big operations, as I know some people here know. What innovation is happening in surgery? And I'll close with this. And one of the big innovations is in robotic surgery. And that's all I'm going to say. And we're going to hear a lot of detail about robotic surgery. And we just so happen to have, I got one more yet, so don't jump up there, Dr. Deutsch. We have some of the top robotic surgeons here at NYU. Now, one thing that I want to get is a second innovation, and this will be very brief, is that, as I just told you, half of people at the time of diagnosis have disease spread, but the other half have localized disease and they're potentially curative. But here's the problem, and Dr. Gonda showed this slide earlier. Many of these patients present as stage 3, meaning they have vessel involvement, and only a small sliver of those in the past were candidates for surgery. So if you have vessel involvement where you have certain criteria, that is called locally advanced unresectable. And up until a few years ago, even though localized disease were not candidates for surgery, remember I said surgery is the only potentially curative treatment. Now, if you're a little squeamish, maybe look away. These pictures are not too bloody, but they do show some patient pictures of what it looks like inside the abdomen. And here you can see a portal vein that has been replaced and going all the way down to where the blood supply comes into the liver. And we can make a large jump up to the portal vein with that and tap in some of the other vessels. Arteries also. Here you can see on this picture a graph that we took blood supply from a right renal artery and took it back to the liver for an artery that was involved with tumor. Here's another example jumping off of the right renal artery. And here's an example where all 3 vessels, each one of those would have been unresectable based on each involvement of each one of these vessels. We're now able to, with these advanced techniques, to be able to remove these tumors. So you can see there, this graft is jumping from the celiac trunk to the liver. You can see the portal vein is reconstructed and the SMA is reconstructed. And in fact, one of the limitations to reconstructing these lesions is the size of the lesion, the size of the vessel we have to jump to. In order to take a vessel out, it's like plumbing. We can take it out and replace it, but we need something to jump to. And even we wear magnifying glasses, even that is not enough. And here's an example of reconstructing a real small vessel under the microscope. We work with a group of microvascular surgeons who do face transplants and things like that. So we have a pretty sophisticated technique where we can chase these vessels higher and higher. So I think that's one of the innovations. And at this point, I'll turn it over to Dr. Deutsch for really a more detailed discussion on robotic surgery. Thank you.
A real privilege to be here today to talk about robotic surgery. Is an area that I'm really passionate about and committed my career to finding less and less invasive surgical ways to take care of pancreatic cancer. So first question I get when patients come in my office is, who's doing the surgery? Is it a robot or is it you? Well, maybe we'll get there one day. Still, surgeons are very necessary. We'll show you a little OR schematic of the setup, but we're doing the whole surgery, and I'll go through exactly why using robotic technology is advantageous. But the surgeon's always in control in the OR and part of a real multidisciplinary team in the OR that makes this possible. And what are the benefits? A lot of you may be familiar with robotic surgery. Computer-guided tools, more precise. You saw Dr. Wolfgang doing microsurgery, but when we do surgery using robotics, it really makes us superhuman. We're able to do really technical things in a very precise way, and you do it under 3D real-time visualization. So this is just a schematic of kind of the setup as it currently exists. You have the surgeon at the console, which is away from the OR table. You have a bedside assistant, usually a physician assistant, that's passing the instruments in and out and doing any suctioning that's required, and the anesthesiologist there that's controlling the table controls. And there's a vision tower where the camera plugs in with a screen monitor for the bedside assistant to look at. So what are the benefits of robotic surgery for pancreatic cancer? Often patients think when you look at the pictures of a Whipple procedure that they're going to come out of the OR looking something like this. And Chris, Dr. Wolfgang went through really in nice detail, but I always like to show this kind of simplified schematic for patients here. Here's the anatomy as was really well defined prior. The tumor in the head of the pancreas. This is the general stuff that has to come out the head of the pancreas, the first port, the duodenum, the gallbladder, and the end of the bile duct. And then those three new connections that we previously alluded to the bile duct, the pancreas, and the end of the stomach. So again, better visualization of really complex anatomy. You saw from those anatomical drawings, it gets really complicated back there around the pancreas. I like to call attention to the reduced physical impact on patients, and I think somewhat psychological impact on patients. You could see on the right side that traditional open surgery, some of the surgeons can do it through smaller midline laparotomies, but generally the patient comes out of the OR with a large scar going back to the beginning of this operation when it was done in the 1900s. Much smaller surgical incisions now, and this varies by surgeon and center, but my current approach is as described here with a C-section scar to get out the final specimen, which I find is really beneficial for patients, significantly less pain and less scarring. There's some evidence also, if you look at the best available studies, that there's less blood loss when it comes to robotic surgery. There might be some patient selection in that, maybe less fluid requirements because the patient doesn't have an open abdomen, less swelling. And then, you think about longer term ramifications from scarring, hernias and wound infections may be lower due to this approach. What about the short-term impact in terms of recovery? It seems like looking at the best available studies, many of them retrospective, that there's shorter hospital stay and faster recovery from these patients. I like to say to my patients, I've seen over the last 8-10 years that they seem to be getting back to who they are more rapidly. And their patients' families also attest to that. And then as Dr. Oberstein talked about chemotherapy, it really is a critical piece, especially when they're getting adjuvant chemotherapy, getting them back to that ability to receive chemotherapy quicker. Potential for more oncologic surgery. There really is no difference based on the studies available today as to whether robotics is better than open approach. I would say they're pretty equivalent, but the best sense I get from the literature is that maybe we're getting more lymph nodes during the robotic surgeries. And why does this matter? Well, we're going to get more accurate staging for those patients and maybe better local regional disease control. Who's a candidate for the robotic approach? I think the indications continue to expand as we've gotten better and better and more experience. I think at NYU, we have an amazing team of experienced robotic pancreas surgeons. So we're really pushing the limit on who can have a robotic approach. But I would say we're definitely not doing the stuff that Dr. Wolfgang alluded to. That's really advanced, complex work. And if you have that kind of tumor locally advanced, it's not going to be a great idea to approach it robotically. And then extensive inflammation and scarring. If you had many previous surgeries, lots of scar tissue, radiation in the past, make it exceedingly challenging and dangerous to do this with a robotic approach. So surgeries, I'd like to close with surgery is only part of the treatment plan. You've seen this from the other speakers. While we like to say that surgery offers our best hope for a cure, multidisciplinary care is so critical. I'm really privileged to work with the team here. You're meeting all of them today, or all the leaders, and then there's a whole other group of people throughout the system in GI, interventional radiology, medical oncology, radiation oncology, as well as our nutritionists and physical therapy, really trying to come up with programs that prepare patients better for the surgery and then the recovery after. And we're well underway working on a prehab program for our patients undergoing robotic surgery, as well as the genetics, social work, and nurse navigation services. So thank you for the opportunity to speak today, and I think we're going to take questions now.
Alrighty, so there's a couple of different questions here that have kind of come up here, and feel free to.
Can I
first
just
ask them
start
first.
some with very naive questions to the surgeons? So two questions. One is, do you ever treat metastatic disease surgically?
That's a great question.
So yes, it's not it's not the majority of patients. If you see maybe 100 patients with metastatic disease, it may be only 5 to 10. And it's based on the principle of what I discussed in that minimal residual disease. If you already have metastatic disease, then obviously you have systemic spread, but we don't know the extent of micrometastatic disease. So after 6 months of chemotherapy, if they have no new lesions, and what is there in terms of within the liver in particular, if it's oligometastatic, so few lesions, and they can be cleared along with the primary, we do it. We're doing it. Brock and Paul are working on a protocol right now to do it. But in highly select patients, it's associated with pretty good survival statistics, in fact, as good as primary. Now, we don't know how much of it is actually the impact of surgery and how much of it is simply biological selection. That's going to require a prospective randomized trial, which is underway. But in the series that we recently published, from my time at Hopkins, we had, I think, 88 patients or something. I think the median survival was around 37 months. So.
The second question is, in some other cancers, people get operated on just to decrease the size of the tumor, even though they know they're not going to remove it totally. So why is this approach never utilized in the setting of pancreatic cancer?
Yeah, I can make the first comment on that. I mean, I think a lot of, as we understand the systemic component of it, that's what you're talking about is called debulking operations, which is shown to actually extend or improve survival in neuroendocrine tumor, another tumor that grows in the pancreas. I mean, I think as we think about it, we actually are doing debulking operations in most patients. But when you have clinical stage 4 disease where you have known liver metastases, say, for example, or carcinomatosis, there's a couple of things. First of all, that usually is what determines survival. It's not the primary tumor. It's what has escaped, in particular, the liver disease. And so removing the primary and leaving liver behind is unlikely to impact it. You say, well, if it's neutral, let's just take it out. As you saw, the problem with pancreas operations, it's much more involved and much more impactful than, say, a colon operation or even a gastrectomy. And so we know that we immunosuppress a patient, which probably accelerates tumor growth. They won't be able to get chemo in the best case scenario for 6 to 8 weeks. And as somebody had presented some data, up to 50% won't get adjuvant therapy. So then in that regard, we make them worse. Now, as we get better and better systemic therapy and more tolerable, there may be a role for debulking.
So I just echo those points. Of course, I'm not a surgeon, but a lot of it, we need to give systemic therapy to really everyone, but certainly anyone who needs quote unquote debulking. And so a lot of it depends on the recovery from surgery, what we think we're accomplishing, but also we're getting much better, hopefully, at tools to detect minimal residual disease, to look at molecular features and biological characteristics of disease. And that's where I think the studies of oligometastatic surgery will make a lot more sense when we can identify the right people to target with that setting.
Great. So a couple of questions came up on the popularity of vaccines and things like that. I know you talked about obviously T-cell therapy and different things like that, but when it comes to the immune system and the concept of vaccines, how does that play a role in treating pancreas cancer?
Yeah, so I'll answer that a little bit. I didn't show any slides about it except very peripherally. The concept behind vaccines is to get, at least in big picture, is to induce the body to develop a response so that it recognizes a target and eliminates it. Works if someone gets measles, for example. One of the challenges in pancreatic cancer fundamentally is that if it's always micrometastatic, there's always cells there, you can't really prevent it if it's already there. So there is a whole nother group of scientists who are looking at preventative vaccines. So patients who are at high risk of developing pancreatic cancer, some of the genetic patients, and giving them a vaccine. But where vaccines are being implemented at this point is trying to identify patients who have the smallest amount of disease or no evidence of minimal residual disease, and giving vaccines after surgery or after completion of chemotherapy. They're not currently being used in patients who have active disease, so measurable disease, but there are studies ongoing in patients without disease to see if they can prevent recurrence. I would say early studies have shown that the body will mount an immune response in response to a vaccine. We have no studies yet that show whether anyone has better outcomes or will live longer. Those studies are ongoing, and hopefully we'll get those answers.
Number of questions around potential complications or lifestyle changes after pancreatectomy as well. So whether it's doing an extensive Whipple or an extensive distal, subtotal distal, or even a total pancreatectomy. So what are some potential things that patients should know as far as, are there any medications they need? How is it going to change their lifestyle as far as, like, are they at risk for hernias and different things like that?
Yeah, I'll start by just talking about kind of the common things. Obviously, as you could see from the demonstration, the anatomy is being changed a little bit. So what I most commonly see in my patients is a process of trying to get back to normalcy. I would say in the short term, diets tend to be smaller in size more frequently throughout the day. There's certain types of food that may or may not agree with particular patients. So we work really closely with our nutritionists to kind of sort out what that is for patients. We also keep them on some type of antacid therapy in the short, intermediate, and in the long term sometimes to reduce the risk of ulcers, which can come up as a result of this surgery. You also mentioned the hernia risk. I think the larger the incision, the larger the risk of the hernia. So that's been really one of my focuses on what are the most convenient or ideal places to extract the specimen and the tumor. And I think using the lower abdominal scar, a lot of data out there currently for colorectal cancer resections that the hernia risk is approaching 0% in those patients. So I'm very optimistic that this approach really reduces that for patients. I don't know if you want to comment.
Yeah, I mean, I agree 100%. Don't have much to add. I could just say that in general, having done this for 20 years and thousands of patients, I think everybody is going to have some pain and discomfort after surgery. Hopefully not extreme. That's pretty rare. But if I ask people what are the things that bother them the most, it's GI issues. And a profound washed out and tired. And usually it's not completely resolved by 3 months, but it starts to get better. In terms of GI upset, as Dr. Deutsch had pointed out, people will eat what's called a post-gastrectomy diet, relatively small meals, but more frequent throughout the day. You fill up, you don't have the best appetite. And it's one of those things where not necessarily food averse, but eating becomes a chore, and ultimately appetite should come back. And it just has to do not with the size of the stomach, that the stomach's smaller, it just has to do with the emptying of the stomach and changes in the physiology. The second thing, and this sort of depends on the aggressiveness of the operation, diarrhea and loose bowel movements are often a problem. It's twofold. There can be pancreatic insufficiency, and part of that just depends on how normal the remaining pancreas is and how good the connection is between the two. That can often be, if it's not good, we can often supplement that with enzyme replacement therapy. But the other aspect is when it's around those vessels that we discussed, in particular the superior mesenteric artery, we have to take the nerve plexus, and people will get a neurogenic diarrhea that can last 6 to 8 months. And we do have some tricks in terms of bulking agents and things that slow down the GI tract to help improve that. But those are really two things that people will struggle with. And then sort of tired and washed out, you leave the hospital, you wake up in the morning, you feel pretty good, but by 11 o'clock in the morning, ready to go back to bed. And the people that recover the quickest from that are the ones who sort of push themselves. I always say it's sort of like training for a sport. But I think those are the two most profound things. And I think there's some people in the room who have actual firsthand experience and can probably talk about their own personal experience with that.
Great. The question came up as far as getting treatment for pancreas cancer. What are some rough numbers or some rough ranges as far as if you can successfully get chemotherapy, if you can successfully get surgery? What are some numbers about patients in terms of their expectation of possible disease recurrence?
I'll take that. So it's a very important question, and of course, very individualized. So every person's, I'd say, prognosis, risk of recurrence, risk of, having or likelihood of having a response depends on the stage of their cancer, the health of the person, and what treatment they're getting. I would say overall, for patients who have surgery, again, it also depends on what is removed. Our hope is that they could be cured by surgery plus chemotherapy. Some studies have shown that up to 40 to 50% of patients will have 5-year survival after surgery. Obviously, if you look at early stage 1 or early stage 1 patients, that number is much higher, 80% or so. But if they're stage 3 and have surgery, it's lower. The true number really is hard to gather from a trial which describes a specific population. On the other hand, patients who have metastatic disease, so stage 4 disease, except with very rare exceptions of which we do see them, but for the vast majority of patients, we're not able to cure them of their disease through chemotherapy. So the goal of chemotherapy is what we call palliative, which means to improve symptoms, prevent worsening of symptoms, prolong life, and prolong good quality of life. And most studies, the study I talked about earlier, shows that today with first-line chemotherapy for metastatic cancer, the median, so close to average survival, is around 10 to 11 months, coming up on a year. Around 40% of patients were alive at a year and a half, and smaller numbers going on. So not numbers that are good for anything that we want to do. They're better than they used to be. So we've made a lot of incremental benefit by months. Our goal is, of course, to get it by years and even longer.
I promise I didn't plant this question. This is on here, but this is a question about histotripsy. When is histotripsy used? So if you don't, I can take that. If you don't
Why don't
want.
you
So
take that one?
just briefly, not to get into too much detail, but histotripsy is an ultrasound-based technology that destroys cancer cells. It goes through the skin, so there's no incision, there's no needle used for that, and it destroys tissue through mechanical destruction, not what is traditional tumor removal or tumor destruction through thermal heat. So it heats things up and gets very, very hot traditionally. But histotripsy is a technology that essentially creates these small micro bubbles that act like bowling balls and essentially put holes in the tissue, and the tissue kind of falls apart that way. So it's not currently approved for treatment directly in the pancreas yet. There's a trial ongoing in Europe for that, which we will at some point like to bring over to the United States, and certainly here at NYU. It's currently FDA approved for treating only liver tumors, although at NYU we also do have a clinical trial set up here that should be finishing here pretty soon to treat primary disease in the kidney as well. So it's FDA approved for treating liver diseases. So when we talked about metastatic disease, one of the most common places pancreas cancer goes is to the liver. So this can be used as an adjunct, as an add-on. It should not be used as a primary therapy, but it can be used in certainly select patients to help treat disease in the liver specifically, but not yet primarily in the pancreas. So one of the last questions here came up. What about time? And we talked about this a little bit, but ideally patients will get both surgery and chemotherapy. Can you just expand a little bit on the role of rather putting chemotherapy first or after, and how does that make a difference for patients?
It's a great, I think it's a great question to close with, because it gets back to the multidisciplinary team. All these patients should really be discussed in a group setting with radiologists going through imaging, gastroenterologists, interventional radiologists, to make sure that there's consensus in the way to take care of these patients. I think as we go on and more clinical trial information comes available, we as surgeons, I think I can speak for Dr. Wolfgang too, is we prefer to get as many patients neoadjuvant chemotherapy as possible. The reason I like neoadjuvant chemotherapy is it allows us, most importantly, the opportunity to find out what that tumor is going to do, and if that patient is a really good candidate for some of these more invasive, more involved surgeries. But as you've heard throughout the day, this is a systemic disease, and getting chemotherapy on board to take care of all the different aspects, not only a local tumor, is advantageous. So I think even though for tumors that are removable, resectable, the standard of care still remains to take those out with surgery and then give chemotherapy after. A lot of us feel the same way, that the future is how can we get these really cutting edge treatments on board as they become available in the upfront setting, so that we are making surgery an option, more of an option for more people, but really selecting those patients better.
And yeah, I just add, I agree with that completely. The multidisciplinary part of this is essential because it needs to be individualized for the patient based on the location of the tumor, the surgical input, and many other factors. There is, however, a large US study, there are European studies as well, going on that's asking this question directly in several hundred patients. We think it'll finish this year and then take a couple of years till we get a readout. So we don't have that data yet, but we're hoping that it will come, and we could definitely use more concrete information such as blood tests or other tumor features to guide who needs chemo upfront and who can go straight to surgery.
All right, well, that's it. Well, we have one more minute. This is a quick little shot from really kind of more the first couple sessions too. Is Lynch syndrome is a question that came up a lot. Like, what is Lynch syndrome? What does it mean for pancreas? And then, are there specific therapies that are better utilized in patients with Lynch syndrome? So if you want to try to answer that briefly.
I can try, though. I'm not a geneticist or that. So Lynch syndrome is a name for a syndrome of DNA mismatch repair deficiency, which means that the body someone was born with a genetic mistake in repairing mistakes and genetic alteration in repairing mistakes in DNA. What happens in that case is that they accumulate many mistakes, and some of those can become cancerous. There's a different cancers that a person with Lynch syndrome is at risk for. One of them is pancreatic cancer. It's not very common at all, but it is possible. And the implication is that if a person with Lynch syndrome or DNA mismatch repair deficiency has pancreatic cancer, they're often very good candidates for therapy with immunotherapy. And so they have a very different outcome and a very different pathway. So it's really critical to get that testing for every patient.
Wonderful.